Alcohol poisoning. Ethanol toxicity. 1. Source and context. Ethanol, CH3CH2O, is found in alcoholic beverages, hand sanitizers, cough syrups, perfumes, industrial solvents. Poisoning may result from binge drinking, accidental ingestion, children, or suicide attempts. Can co-ingest with other alcohols like methanol or ethylene glycol. Diagnostic challenge. 2. Mechanism of toxicity. CNS depressant, potentiates GABA receptor, inhibits NMDA glutamate receptors. Causes dose-dependent CNS depression, from euphoria, sedation, coma. Also causes vasodilation, hypoglycemia, and metabolic acidosis. Chronic use. Hepatic injury, gastritis, Wernicke's encephalopathy, pancreatitis. 3. Clinical features. Acute ethanol poisoning, low doses, euphoria, disinhibition, impaired judgment. Higher doses, slurred speech, ataxia, nausea, vomiting, hypoglycemia. Severe toxicity, respiratory depression, hypotension. Coma. Hypothermia due to vasodilation, hypoglycemia especially in children or fasting adults, lactic acidosis from impaired gluconeogenesis. Chronic abuse features, hepatic, fatty liver, hepatitis, cirrhosis. Neurological, Wernicke's encephalopathy, thiamine deficiency, cerebellar degeneration, gastrointestinal, gastritis, pancreatitis. Hematologic, macrocytic anemia. 4. Investigations. Blood ethanol level, to quantify blood glucose, risk of hypoglycemia. Why hypoglycemia? Ethanol inhibits gluconeogenesis by raising the NADH-NAD ratio in hepatocytes, diverting pyruvate to lactate and preventing glucose production. ABG, may show metabolic acidosis. Serum electrolytes, look for anion gap, osmolyl gap. LFTs, amylase lipase. If chronic use suspected. CT brain. If altered consciousness, rule out trauma or intracranial bleed. 5. Management. Supportive care, airway, breathing, circulation. ABCs, secure airway. If GCS8, monitor vitals, temperature, glucose. IV fluids, for hypotension and dehydration. Thiamine 100 mg IV. Before glucose. If Wernicke's encephalopathy is suspected. Correct hypoglycemia with IV dextrose. Active warming. If hypothermic, no role of activated charcoal in pure ethanol ingestion. Enhanced elimination, rarely required unless co-ingestants e.g., methanol, ethylene glycol, present. Hemodialysis if severe toxicity with metabolic derangement or renal failure. 6. Prognosis good with supportive care unless co-ingestants or complications e.g., aspiration, seizures, occur. Chronic use. Long-term complications, needs de-addiction counseling. TCA poisoning. Tricyclic antidepressants. 1. Source and context. Common TCAs, amitriptyline, nortriptyline, imipramine, doxepin, clomipramine. Used for depression, chronic pain, insomnia, migraine. Prophylaxis. Toxic dose, 10-20 mg/kg equals toxic, 30 mg/kg equals potentially fatal. High morbidity due to cardiotoxicity and seizures. Peak toxicity, 2 to 6 hours post-ingestion. Beware delayed deterioration. 2. Mechanism of toxicity. Multi-system toxic effects, sodium channel blockade. QRS widening, arrhythmias. Inhibits norepinephrine and serotonin reuptake. CNS stimulation. Anticholinergic effects, mydriasis, dry mouth, tachycardia. Antihistaminic and anti-alpha sedation, hypotension. GABA antagonism. Seizures. 3. Clinical features. Anticholinergic syndrome, hot, dry skin. Mydriasis. Tachycardia. Urinary retention. Delirium. Agitation. Cardiovascular, QRS widening, 100 ms. Predicts seizures, 160 ms. Risk of VTVF. Prolonged QT. PR. Ventricular arrhythmias. Hypotension. Vasodilation plus myocardial depression, central nervous system, drowsiness. Seizures. Coma. Respiratory depression. Myoclonus. 4. Diagnosis. ECG is key. QRS, 100 ms. Risk of seizures. QRS, 160 ms. Risk of ventricular arrhythmias. R-wave and AVR, 3 mm. Specific for TCA toxicity. QT and PR. Prolongation. Bloods, ABG. Metabolic acidosis. Common electrolytes. Drug levels rarely helpful in acute setting. Glucose, to rule out hypoglycemia-related altered mentation. 5. Management. A. Stabilization. ABCs, secure airway, ventilate early if GCS8. Cardiac monitoring. Continuously IV access and fluids. B. Decontamination, activated charcoal. 1 g/kg. If 1-2 HRS and airway protected. C. Specific antidote. Sodium bicarbonate. Mainstay of therapy. Indications, QRS, 100 ms, hypotension, arrhythmias. Dose, 1-2 mEq kg IV bolus repeat until QRS narrows goal. Serum pH 7.45 to 7.55 mechanism. Overcomes sodium channel blockade. Alkalinizes serum. Reduces free drug seizure management. Benzodiazepines e.g. lorazepam, diazepam. Avoid phenytoin. May worsen cardiac toxicity e hypotension, fluid bolus if unresponsive, norepinephrine preferred, avoid pure beta agonists like dopamine, F arrhythmias, bicarbonate first lidocaine if refractory VT. Avoid class IANIC antiarrhythmics. G intralipid therapy, may be considered for refractory cardiotoxicity, off-label. 6. Prognosis. Most deaths occur within first 24 hours. Good outcome if QRS 100 ms and no seizures. Monitor minimum 6 to 12 hours post-ingestion. Risk factors for poor outcome. Coma. QRS 160 ms ventricular arrhythmias, acidosis, seizures, organophosphate OP poisoning. 1. Source and context. Organophosphates are irreversible acetylcholinesterase inhibitors, used in agriculture, insecticides, pesticides e.g., malathion, parathion, chlorpyrifos, domestic, contaminated food or water, bioterrorism, warfare. Nerve agents, sarin, soman, VX roots, inhalation, ingestion, dermal absorption. Mechanism of toxicity. Inhibits acetylcholinesterase, ACE, accumulation of acetylcholine at muscarinic, nicotinic, and CNS synapses. Aging. Permanent binding of OP to ACE enzyme, preventing reactivation. Onset depends on agent and route, minutes to hours. 3. Clinical features. Mnemonic, dumbbells plus CNS plus nicotinic, muscarinic, dumbbells, diarrhea, urination, meiosis, bradycardia, bronchorrhea, bronchospasm, emesis, lacrimation, salivation, sweating, nicotinic. Muscle fasciculations, weakness, paralysis, hypertension, tachycardia, sympathetic ganglia stimulation, central nervous system, anxiety, confusion, seizures, coma, respiratory failure, central depression plus NMJ, weakness plus bronchorrhea. Diagnosis. Clinical, cholinergic toxidrome is hallmark. Supportive tests, RBC plasma cholinesterase, pseudocholinesterase CXR, if aspiration or excessive secretions, ABG, hypoxia, acidosis, ECG, QT prolongation, bradyarrhythmias. Management. A decontamination. Remove patient from source. Remove clothes, wash skin. Gastric lavage. Activated charcoal if within 1 hour. B supportive care. Airway protection, often early intubation. Oxygen. Ventilation. Suction. Secretions, manage bronchospasm. See antidotes. 1. Atropine, blocks muscarinic effects. Dose, start with 1-3 mg IV, double every 5 minutes until lungs dry. NHR improves. Large doses often required, 100 mg day possible. 2. Oximes reactivate ACE before aging, pralidoxime, 2 pam. 30 mg kg IV over 30 minutes, then infusion. Most effective if given within 24 HRS. Reverses nicotinic effects only. 3. Benzodiazepines, for seizures, e.g., diazepam, midazolam. Special notes. Atropinization endpoint, clear chest unauscultation, not just pupil dilation or HR. Oximes do not reverse muscarinic symptoms. Atropine is needed. Intermediate syndrome. Onset. 24-96 HRS. Post-exposure features, proximal muscle weakness, cranial nerve palsies, respiratory failure, may require prolonged ventilation. Delayed neuropathy, OPIDN, onset. Weeks later. Irreversible peripheral neuropathy not prevented by atropine or oximes. Prognosis, good if treated early and aggressively. Poor prognosis in delayed presentation, massive ingestion, respiratory failure or seizures. Intermediate syndrome, ethylene glycol poisoning. Source and context. Ethylene glycol is a toxic alcohol found in antifreeze. Most common, industrial solvents, de-icing solutions, brake fluid, usually ingested accidentally. Children, pets, or intentionally. Suicide attempts. Sweet taste, increased risk of accidental ingestion, often co-ingested with ethanol or methanol. Mechanism of toxicity. Ethylene glycol itself is not highly toxic, but it is metabolized by alcohol dehydrogenase ADH to toxic metabolites. Toxic metabolites, in order. 1. Glycolaldehyde. 2. Glycolic acid. Metabolic acidosis. 3. Glyoxylic acid. 4. Oxalic acid binds calcium oxalate crystals in kidneys. Key effects: high anion gap, metabolic acidosis, high osmolar gap, early hypocalcemia, renal failure from crystal deposition. Clinical features: stage 1 CNS depression, 30 mins 12 HRS, similar to alcohol, ataxia, confusion, slurred speech seizures, coma, severe cases, stage 2 cardiopulmonary, 12-24 HRS, tachycardia, hypertension or hypotension pulmonary edema, ARDS cardiovascular collapse, severe acidosis. Stage 3 renal toxicity 24-72 HRS, flank pain, hematuria acute tubular necrosis, oliguric renal failure hypocalcemia tetany, QT prolongation, investigations initial labs. ABG high anion gap metabolic acidosis serum osmolality calculate osmolar gap electrolytes anion gap, hypocalcemia urinalysis calcium oxalate crystals, envelope needle shaped, serum ethylene glycol level, if available, other, urea. Creatinine renal injury ECG QT prolongation, if hypocalcemic, management A stabilize first airway, breathing, circulation correct hypoxia, acidosis, seizures B prevent metabolism to toxic metabolites 1. Famepizole, first line, inhibits alcohol dehydrogenase dose. 15 mg kg IV, then 10 mg kg Q12H preferred due to fewer side effects 2. Ethanol, if famepizole unavailable, competes with ethylene glycol for ADH requires ICU monitoring narrow therapeutic window, c. Enhance elimination hemodialysis if severe acidosis, pH 7.1 renal failure high ethylene glycol level, 50 mg/dl, electrolyte disturbances or deteriorating condition D cofactor therapy, to shunt non-toxic pathways, thiamine 100 mg IV Q6H. Pyridoxine, 50 mg IV Q6H, magnesium if low E treat hypocalcemia only if symptomatic seizures, tetany, QTC, prognosis excellent with early antidote use and dialysis poor if delayed diagnosis, severe renal failure, or coma. Carbon monoxide CO poisoning source and context carbon monoxide is a colorless, odorless, non-irritant gas produced by incomplete combustion of carbon-containing fuels. Common sources: house fires, gas heaters, wood stoves, car exhaust, shisha hookah smoking, faulty generators and enclosed spaces. Risk groups: children, pregnant women, fetal HB affected more, elderly patients with cardiac respiratory disease. Mechanism of toxicity: CO binds hemoglobin HB, with 200-250 times greater affinity than oxygen, forms carboxyhemoglobin, COB. Oxygen delivery to tissues, leftward shift of O2 HB dissociation curve. Impairs mitochondrial oxidative phosphorylation. Also affects myoglobin, myocardial dysfunction, cytochrome oxidase, direct cellular hypoxia. Clinical features: nonspecific symptoms, suspicion is key, mild to moderate, headache. Most common early sign: dizziness, confusion, nausea, vomiting, flu-like symptoms, but afebrile, tachycardia, severe poisoning, syncope, seizures, coma, hypotension, arrhythmias, myocardial ischemia, especially in IHD. Lactic acidosis, cherry red skin, rare, late finding, pregnancy, fetal distress, stillbirth. Fetal HB has higher affinity, prolonged exposure risk. Diagnosis: clinical suspicion if exposure plus unexplained neuro or cardiac symptoms confirm with COB level, arterial venous blood gas with co-oximetry, normal, 2%, non-smokers, 10%, smokers, mild, 10 to 20%, moderate, 20 to 40%, severe, 40%. Note: pulse oximetry is falsely normal, can't differentiate COB from oxy-HB. ABG may show metabolic, lactic, acidosis. Other investigations: ECG, troponin if cardiac symptoms, CT brain if prolonged unconsciousness. Management: immediate. 100% oxygen, non-rebreather mask, COB half-life, room air, 4-6 HRS 100% O2, 1 hour hyperbaric O2, 20 to 30 minutes. Consider hyperbaric oxygen therapy, HBOT, if COB, 25% loss of consciousness or coma. Neurologic symptoms: seizures, focal deficits, severe metabolic acidosis. Pregnancy with COB, 15% or fetal concerns. Supportive care, airway protection if GCS, low IV fluids for hypotension, anticonvulsants for seizures. Prognosis and complications: most recover fully with early treatment. Delayed neuropsychiatric syndrome DNS in 10 to 30%. Onset: days, weeks later. Symptoms: memory loss, personality change, Parkinsonism. Risk with coma, elderly. Delayed therapy: snake bite poisoning. Common scenario: patient with vomiting, salivation, ptosis, diplopia, dysphagia, hypotension, e.g., 80/40 mmHg. Tachypnea, GCS drop suspicion of neurotoxic snakebite e.g., cobra, kite, types of poisonous snakes families, viparity, Russell's viper, pit viper elapidae, cobra, kite, coral snake hydrophyty, sea snake. Pathogenesis and venom effects. Venom equals mix of proteins and peptides injected via fangs. Toxicities, hemotoxicity, vascular permeability, bleeding, hypotension, shock, cytotoxicity, local necrosis. Myoglobinuria, renal failure, neurotoxicity, inhibits nerve transmission, paralysis, cardiotoxicity, myocardial depression, coagulopathy, clotting defects, bleeding. Clinical features by snake type: viparity, Russell's, pit viper, local. Swelling, ecchymosis, blistering, systemic, vomiting, shock within 30 minutes, bleeding, gums, venipuncture sites, internal coagulopathy, may be fatal. Elapidae, cobra, kite, minimal local reaction. Early neurosigns: ptosis, diplopia, dysphagia, salivation, respiratory muscle paralysis, myocardial depression, BP, shock, hydrophyty, sea snake, rhabdomyolysis, myalgia, myoglobinuria, ARF, cardiac respiratory paralysis. Investigations: blood group and cross-match. Early before venom alters typing, CBC, urea, creatinine, electrolytes, LFTs, coagulation profile, PT, APTT, beta, CT, FDP, urine, hemoglobinuria, myoglobinuria, ABGZCG, chest X-ray. Initial general management: observe 12-24 HRS even if asymptomatic. Reassure, not all snakes are venomous, dry bites common, 50%, immobilize limb, reduce venom spread, apply firm bandage, lymphatic occlusion, not arterial, avoid tourniquet incision, suction of site NSAIDs, bleeding risk, supportive care, IV fluids, BP support, dopamine, symptomatic, analgesia, paracetamol preferred, insert large bore IV line in unaffected limb. ABC approach: NICU management, airway and breathing indications for intubation. 1. Excessive salivation. 2. Airway blockage. 3. Aspiration. 4. Respiratory muscle weakness, paralysis. 5. Circulatory arrest, secure airway early if deterioration seen. Circulation, IV fluids, vasopressors if hypotensive, anti-venom therapy. Definitive treatment, when to give, progressive local reactions, systemic signs or abnormal labs, coagulopathy, neurosigns, facts. Same dose for adults and children. Ineffective if complications already developed, should be given early administration. Test dose 0.02 milliliters SC. Watch 10 minutes for reaction. Pre-medication, IV antihistamines plus ranitidine plus or minus steroids. Keep adrenaline 0.5 ml 1000 SC ready. Dilute in 1000 milliliters NSRLD 5W. Children 20 ml kg, infuse over 1 to 4 hours. Monitor for anaphylaxis throughout. Continue antivenom even if mild allergy occurs, with adrenaline, antihistamines, steroids. Note, skin testing is not always reliable, false plus VEVA. Key: Viva pearls, dry bite in 50% of venomous snake bites. Tourniquet is contraindicated. Do not delay antivenom if indicated. Neurotoxic signs: progress, anticipate intubation. Viparity equals bleeding plus swelling. Elapidae equals neuro plus no swelling. Hydrophyty equals rhabdomyolysis plus ARF. Long QT syndrome, LQTS definition. Long QT syndrome is a cardiac electrical disorder characterized by a prolonged QT interval on ECG, 440 Ms in men, 460 Ms in women when corrected for heart rate. It reflects delayed ventricular repolarization and predisposes to life-threatening arrhythmias. Pathophysiology: QT interval equals duration of ventricular depolarization and repolarization. Prolongation: increased risk of early afterdepolarizations. EDS, triggers torsades de points, TDP, may degenerate into ventricular fibrillation, VF, and sudden cardiac death. Causes of prolonged QT interval. 1. Congenital LQTS, inherited channelopathies, LQTS type 1, KCNQ1 gene, triggered by exercise, especially swimming. LQTS type 2, KCNH2 gene, triggered by emotional stress or auditory stimuli. LQTS type 3, SCN5A gene, bradycardia related. During sleep. 2. Acquired LQTS, electrolyte abnormalities, hypokalemia, hypomagnesemia, hypocalcemia. Medications: QT prolonging drugs, antiarrhythmics, amiodarone, sotalol, quinidine, procainamide. Antibiotics: erythromycin, clarithromycin. Fluoroquinolones antipsychotics, haloperidol, thioridazine antidepressants, TCAs, SSRIs others, methadone, chloroquine other causes, hypothermia myocarditis acute MI increased sympathetic tone, clinical features. Often asymptomatic syncope, often exertional or stress-induced seizure-like episodes due to cerebral hypoperfusion sudden cardiac death especially in young athletes, torsades de points on ECG, polymorphic VT with shifting axis. ECG findings, prolonged QTC, 440 Ms in men, 460 Ms in women notched or biphasic T waves torsades de points, twisting QRS complexes around isoelectric line, management. 1. Acute management of TDP, IV magnesium sulfate 2 grams over 10 to 15 minutes, even if Mg is normal, defibrillation if patient is pulseless or in sustained VT-VF overdrive pacing or isoproterenol infusion for bradycardia-induced TDP stop all QT. Prolonging drugs correct electrolytes, K, 4.5 mol Lmg to the power of 2, 2 mg dl normal calcium 2. Chronic preventive management, beta blockers, non-selective, propranolol or nadolol, first-line left cardiac sympathetic denervation, LCSD, if refractory or contraindicated beta blocker implantable cardioverter defibrillator ICD. History of cardiac arrest or symptomatic despite treatment lifestyle modifications, avoid strenuous activity if high risk avoid loud alarms 3. Genetic counseling, for patients and family members with congenital LQTS, mnemonic for causes, Chimes QT congenital hypocalcemia ischemia MI, myocarditis medications antiarrhythmics, macrolides, antipsychotics. Electrolyte imbalances, K, Mg, Ca, sympathetic excess quinidine thioridazine, hydrocephalus definition pathological accumulation of CSF in the ventricles of the brain, leading to ventricular dilation and increased intracranial pressure ICP types of hydrocephalus 1. Communicating hydrocephalus CSF flows freely through ventricles, but impaired absorption at the arachnoid granulations. Causes, meningitis subarachnoid hemorrhage post-surgical scarring congenital e.g., Chiari-2, ICP, usually 2. Non-communicating, obstructive, hydrocephalus blockage within the ventricular system, preventing CSF flow. Common sites, aqueduct of Sylvius, foramen of Monroe. Causes, aqueductal stenosis tumors e.g., pinealoma, colloid cyst congenital malformations ICP. 3. Normal pressure hydrocephalus, NPH enlarged ventricles but normal CSF pressure. Classic triad, gait disturbance magnetic gait, dementia urinary incontinence etiology, idiopathic, post-SA, trauma. Management, responds to CSF drainage shunting 4. Hydrocephalus ex vacuo not true hydrocephalus. Ventricular enlargement due to brain atrophy e.g., Alzheimer's. CSF volume increases passively, no raised ICP, clinical features, raised ICP headache worsen AM, nausea vomiting papilledema altered consciousness 6th nerve palsy early sign, sunset eye sign in infants, management temporary. External ventricular drain, EVD, lumbar puncture NPH trial definitive, VP shunt, ventriculoperitoneal, endoscopic third ventriculostomy, ETV, especially in obstructive types. Aspiration under general anesthesia. Definition: pulmonary aspiration is the inhalation of gastric contents, solid or liquid, into the respiratory tract. Under GA, it usually occurs due to loss of airway reflexes or improper airway protection. Causes risk factors. 1. Patient-related, inadequate fasting, emergency cases, delayed gastric emptying gastroesophageal reflux disease, GERD, obesity intra-abdominal pressure, pregnancy especially second and third trimester diabetes mellitus. Autonomic gastroparesis trauma or bowel obstruction neurological disorders affecting swallowing 2. Anesthesia-related, light plane of anesthesia poor airway control, face mask, LMA instead of ET, inadequate cricoid pressure supine or Trendelenburg position delayed recovery with residual sedation pathophysiology. Solid aspiration acute obstruction bronchial blockage, atelectasis acidic liquid chemical pneumonitis, Mendelssohn's syndrome, this leads to alveolar epithelial damage surfactant loss capillary leak pulmonary edema inflammatory response ARDS, clinical features, sudden desaturation and hypoxia cough, wheeze, or bronchospasm pink frothy secretions tachypnea and respiratory distress decreased breath sounds, often right lower lobe, infiltrates on CXR within 2 to 6 hours, right middle lower lobes, immediate intraoperative management. Stop surgery if possible. Positioning, head down, Trendelenburg, right lateral if supine, to limit spread suction, oropharynx and deep suctioning of trachea bronchi. After intubation, secure airway. Tracheal intubation with cuffed avoid LMA face mask. Further 100% oxygen plus PEEP, improve oxygenation. Limit shunt bronchodilators if wheeze bronchospasm present. Consider bronchoscopy if particulate matter suspected. No prophylactic antibiotics unless foul smelling, feculent, aspirate or fever or sepsis present. Steroids not routinely used. Postoperative management, detailed monitoring, IQ-HDU admission, continuous pulse oximetry and respiratory monitoring. Serial ABGs PAO2, PACO2, lactate, CXR at 4 to 6 hours. Monitor for ARDS, secondary infection, sepsis. Supportive management, oxygen therapy, high-flow nasal oxygen or CPAP, ventilatory support, invasive ventilation if hypoxia persists, ARDS, fluid balance, avoid overload worsens pulmonary edema, analgesia. Judicious use, avoid respiratory depression. Medical therapy, antibiotics, only if clinical signs of infection develop, fever, raised WBC, positive cultures, broad-spectrum e.g., coamoxiclav or piperacillin tazobactam. If indicated, bronchodilators if bronchospasm present. Steroids, not used in aspiration pneumonitis. Consider only in ARDS or severe bronchospasm. Physiotherapy, chest physiotherapy and incentive spirometry. 1 stable. Complications to watch for: ARDS, ventilator-associated pneumonia, lung abscess, bronchial obstruction if solids not cleared, sepsis, death, if massive or untreated. Prevention in high-risk patients. Proper fasting, H2 blockers or PPIs, prokinetics, metoclopramide, RSI with cricoid pressure. Consider awake intubation in difficult airway, nasogastric decompression and bowel obstruction. Postoperative confusion, 414. Cyprian scenario, called to assess a patient in PACU who is confused and agitated. Initial assessment, follow the ABC approach, airway, breathing, circulation. Administer 100% oxygen. Check vital signs, causes. 1. Pharmacological, residual effects of anesthetic drugs, inadequate recovery from muscle relaxants, opioids. 2. Metabolic, physiological, hypothermia or impaired drug metabolism, pain e.g., full bladder, surgical ileus. 3. Cardiovascular, hypotension, hypovolemia, arrhythmias. 4. Respiratory, hypoxia, hypercapnia e.g., pneumonia. Other causes, neurological, stroke, CVA, intracranial pathology, seizures, infectious, meningitis, respiratory tract infections, RDI, urinary tract infections, UTI. Withdrawal states. Alcohol withdrawal, psychiatric, underlying personality disorders. How would you investigate? Review anesthesia chart, timing, drugs used. Check duration of inhalational agent discontinuation. Consider antidotes if indicated. Perform neuromuscular NM monitoring. Consider repeating neostigmine, not more than 5 mg total. Check blood glucose, electrolytes. Temperature. Obtain ECG for arrhythmias. Perform ABG PAO2, PACO2, and consider ICU transfer if needed. Latex allergy, from Cyprian risk groups, healthcare workers, up to 17%. Spina bifida patients, up to 60%. Rubber industry workers, recurrent surgical catheterization history. Fruit allergy, banana, avocado, kiwi, chestnut, cross-reactivity, prior unexplained anaphylaxis during surgery. Clinical presentations. 1. Irritant contact dermatitis, non-allergic, due to direct skin damage from glove components. 2. Type IV hypersensitivity, delayed contact dermatitis, T-cell mediated due to additives, antioxidants, accelerators, in latex processing. 3. Type I hypersensitivity, IgE mediated, can range from urticaria, asthma, to anaphylaxis, occurs on re-exposure in sensitized individuals. Pre-op precautions for latex allergy, inform all staff first on OT list. Remove all latex containing equipment from theater and anesthetic room use. Latex-free gloves, catheters, airways, etc. Prepare for anaphylaxis, adrenaline, atropine, hydrocortisone, salbutamol. Recovery in latex-free environment, e.g., inside theater. Anaphylaxis definition, IgE-mediated, type I, reaction, mast cell degranulation, histamine, leukotrienes. TNF release, anaphylactoid reaction, non-IgE-mediated drugs. Agents directly activate mast cells. No prior sensitization required. Clinically indistinguishable and managed identically. Clinical features: cardiac, tachycardia, hypotension. collapse respiratory, bronchospasm, wheeze, pulmonary edema, skin, urticaria, angioedema, gastrointestinal, vomiting, abdominal cramps, diarrhea. In 10%, CV collapse may be the only feature worse in patients on beta blockers or neuraxial anesthesia. Blunted sympathetic response, management of anaphylaxis including latex-induced, primary management, call for help, stop surgery and latex exposure, lay patient flat. Elevate legs, 100% oxygen, adrenaline, IV 50 to 100 mcg, titrate or IM 0.5 to 1 mg q 10 min as needed. Fluids, Hartmann's or NS to 1L rapid bolus, up to 2 to 4L secondary management, chlorpheniramine, 10 to 20 mg slow IV hydrocortisone, 100 to 500 mg IV bronchodilators, salbutamol if bronchospasm, inotropes, as needed for persistent hypotension. ABG to assess and correct acidosis. Monitor in HDU-IQ for 24H. Investigations immediate during reaction. 1. Serum tryptase, marker of mast cell degranulation. 3 samples, as soon as possible after resuscitation at 1 hour at 6 hours storage. 4 degrees Celsius if analyzed within 48H - 20 degrees Celsius if delayed. Peaks at 1H. Transient rise. Note, normal tryptase does not rule out anaphylaxis delayed. After 4-6 weeks, in vivo tests, risk of reaction, Resus facilities needed. Skin prick test, higher antigen concentration. Intradermal test, uses diluted antigen, more sensitive, must be done in specialist allergy clinic. In vitro tests, safe. RAST, radioallergosorbent test. Detects specific IgE in serum. No risk of provoking a reaction for select anesthetic drugs, e.g., succinylcholine. Specific IgE can be tested. Follow-up. Refer to allergy center. Include full anesthetic surgical record details. Time of reaction, clinical features, drugs, fluids given before, after, response, investigations. Medic alert bracelet, written notification to patient plus GP report to Committee on Safety of Medicines, Yellow Card Scheme UK. Role of epinephrine in anaphylaxis. Epinephrine, adrenaline, is the first-line, life-saving drug in the treatment of anaphylaxis. It addresses all major pathophysiological mechanisms of anaphylaxis. 1. Alpha-1 adrenergic effects. Vasoconstriction reverses hypotension and reduces mucosal edema, especially in larynx. Increases peripheral vascular resistance, supports blood pressure. 2. Beta-1 adrenergic effects, increases heart rate and myocardial contractility, supports cardiac output during shock. 3. Beta-2 adrenergic effects, bronchodilation, relieves bronchospasm, stabilizes mast cells and basophils, decreases further release of mediators, e.g., histamine. Additional actions. Improves coronary perfusion, shortens duration and severity of reaction, prevents biphasic reactions if given early. Dosage, IM preferred in community ward. 0.5 mg of 1,000, i.e., 0.5 ml, every 5 to 10 minutes as needed. IV severe refractory cases in monitored settings. 50-100 mcg boluses of 110,000 solution, can use infusion if needed.